Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about a very fascinating topic: accommodation and ciliospinal reflexes. Accommodation and ciliospinal reflexes, cranial nerves part 22, oculomotor nerves part 8. Accommodation and ciliospinal reflexes. So today we are going to discuss two reflexes, the accommodation reflex and the ciliospinal reflex. The accommodation reflex near response is elicited by having the patient relax accommodation by gazing into the distance, then shifting gaze to some nearby object. So the best near object is the patient's own finger or thumb. So when we shift the gaze from a distance to a near object, it causes blurring, and this forms as a stimulus for evoking the accommodation reflex. The response consists of thickening of the lens, that is accommodation, convergence of the eyes, and miosis, that is the constriction of the pupils. The primary stimulus for accommodation is blurring. Without the near response, attempting the focus on a close object would result in a blurred vision. Accommodation occurs because contraction of the ciliary muscles relaxes the zonular fibers, permitting the lens to become more convex because of its inherent elasticity. Accommodation is measured by diopters. The convergence movement of the near reflex is mediated by the vergence subcomponent of the supranuclear ocular motor system. It consists of contraction of both medial rectus muscles. So accommodation reflex also, like pupil light reflex, it starts in the optic nerve. It goes till the lateral geniculate body. Pupil light reflex, just before the lateral geniculate body, it crosses over and goes to the midbrain, whereas the accommodation reflex continues to the lateral geniculate body and beyond to the occipital cortex. From there it goes to the frontal cortex. From there, without going to the pretectal nucleus, it goes to the Edinger-Westphal nucleus. And then it goes to the pupillary muscles and causes the pupillary contraction. The pupils constrict at near to increase the depth of focus. The pathways involves the visual cortex, as I said, goes from the lateral geniculate body to the visual cortex, with impulses probably descending to the corticotectal tract to near response cells near the pretectum, and it goes directly to the Edinger-Westphal nucleus. The midbrain mechanisms for pupillary constriction to near are separate from those for the light reflex. One response may be abnormal whereas the other is preserved. For example, accommodation reflex may be present and light reflex may be absent in neurocephalus, which is known as Argyll-Robertson pupil, where the lesion is in the pretectal nucleus, affecting the light reflex pathway but sparing the accommodation reflex pathway. Disorders that affect the dorsal rostral brainstem may affect the light reaction but leave the near reaction intact. Pressure on the pupillary fibers in the region of the pretectum and the posterior commissure impairs the light reaction. However, fibers mediating the near response are spared, which leaves the near responses intact. Example, piniloma. Other disorders include Argyll-Robertson pupil and Addis pupil. Now we'll talk about the ciliospinal reflex. The ciliospinal reflex consists of dilatation of the pupil on painful stimulation of the skin of the ipsilateral neck. The local cutaneous stimulation, that is the scratching the neck, activates the sympathetics through the connections with the ciliospinal center at CAT2 that causes the ipsilateral pupil to dilate. An intact ciliospinal reflex is evidence of brainstem integrity when evaluating a comatose patient. We all know that there are three orders of the sympathetic pathway: one coming from the hypothalamus going through the brainstem till the C8T2. Second order comes from the C8T2, goes over the apex of the lung to the superior cervical ganglion, and third order goes from the superior cervical ganglion to the pupilodilatory fibers. So the first order comes from the hypothalamus, goes to the brainstem to the C8T2, and therefore when one with the local cutaneous stimulus, example scratching the neck, activates sympathetics through the connection with the ciliospinal center at C8T2 that causes the ipsilateral pupil to dilate, and therefore an intact ciliospinal reflex is evidence of the brainstem integrity when evaluating a comatose patient. So these are all the important concepts of the accommodation reflex and the ciliospinal reflex. The other important concepts I put in a book called Focused Neurology, written by me, Sreenivas, which is available online from all leading booksellers including Amazon. If interested, it could be bought online. If you have liked these concepts, if you have enjoyed these concepts of accommodation reflex and ciliospinal reflex, please like it and share the link with your friends. But please subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my webpage, Dr. Sreenivas Concepts. Thank you. Bye.